let me just see. يقول لي you are muted. Could حد يأكد لي أنا muted ولا لا؟ No? Okay. All right. I guess I'm not muted. So صح أشربتكم لأخوتنا الطلبة اللي فطروا. I chose to نحط لكم السلايد هذه because I know إنكم معظمكم حيكونوا طبعا طلبة سنة رابعة. و for the most part I think في خلال سنوات الطب هادو أحلى سنوات لأن هادو this is when you put it all together. كل اللي تعلمته في سنة أولى وثانية وثالثة من الفسيولوجي للأناتومي للpathology and the microbiology, this is when it really finally makes sense وتحس نفسك فعلا إنك أنت وتحسي نفسك دكتور البالتو despite the fact إنه السنوات اللي فاتوا أصعب سنة رابعة وسنة خامسة clinical as much as it is fun it is very challenging but I want you to remember just one thing. I want you to not wish it was easier but wish you were better. Don't wish for less problems, wish for more skills. Don't wish for less challenges but for more wisdom, and you will see that inshallah خلال كل سنوات الطب هذه you are getting better. And you are getting more skillful as you learn new tricks. And part of the wisdom حيجي مع الوقت. The other part will see من كثرة الحياة. And I realize that it may sound that it is very tough and it keeps getting tougher, but this is how you become who you are, and hopefully that will be a skillful physician, inshallah. So our topic today حيكون على postpartum hemorrhage. And when I think of postpartum hemorrhage, I have a special connection to it because it is unfortunately very common and it's something you will see to varying degrees. So it may not be a catastrophic, severe hemorrhage that you will see every time, but it is very common. And it is an obstetrical emergency. It is one of the top 5 causes of maternal mortality in both high and low per capita income countries. So I mean, this is the top 5 reasons for why we lose moms during childbirth. When it's timely recognized, appropriate resources and appropriate response are critical for preventing mortality and major morbidity. So today's objectives, and I know ما تنخلعوش بالليسة because it looks very, very long, but I hope that we will be able to go through everything here. So the first thing we're going to do is try to go over the definition and diagnosis of postpartum hemorrhage. We're going to try to discuss the incidence of postpartum hemorrhage. What are the physical mechanisms that limit postpartum blood loss, causes of postpartum hemorrhage, risk factors and specific etiologies contributing to postpartum hemorrhage, as well as assessment and management of postpartum hemorrhage. And then I would like to touch on planning/prevention. If there is such thing, we can always try. And then the mortality and morbidity associated with postpartum hemorrhage, and we'll touch a little bit on the recurrence of postpartum hemorrhage as well. So first things first. I don't know if من الhosts could just make sure, I don't know why this keeps في تخربيش على الشاشة, and I think maybe inadvertently somebody's touching the screen. But anyways, so when you look at the definition of postpartum hemorrhage, so just to simplify it, I will be talking about primary postpartum hemorrhage or early postpartum hemorrhage, which is usually hemorrhage that occurs in the first 24 hours after delivery. Anything that happens beyond the 24 hours post-delivery up to 12 weeks postpartum is usually secondary hemorrhage, secondary postpartum hemorrhage, and I will not be addressing it today. So when do we make the diagnosis of postpartum hemorrhage? We do it when bleeding is greater than expected and results in signs and or symptoms of hypovolemia. And I know it sounds adverse, but bear with me and I will explain to you why this makes the most sense. Because there are multiple other criteria for diagnosing postpartum hemorrhage, and they are used worldwide. And I will go through it. But traditionally, it has been defined blood loss in a vaginal delivery in 1,000 cc for a C-section. But in 2017, the American College of OBGYN revised the definition and decided to define it as a cumulative blood loss of more than 1,000 cc's or bleeding that is associated with signs, symptoms of hypovolemia within 24 hours of the birth process, regardless of the mode of delivery. So regardless whether it's a vaginal delivery or a C-section, anything over 1,000 cc's blood loss is considered postpartum hemorrhage. And when you think about what are the associated symptoms, what are the symptoms associated with the blood and the postpartum hemorrhage, it's been classified in, if you look at this table, depending on the percentage of blood loss or the amount of blood loss lost. So a blood loss of about 10 to 15% of 1,000 cc's is considered within normal range, normal, and the patient has various usually palpitations, lightheadedness, mild. Over this patient is able to go around the knee and lightheaded. When you have blood loss of 15 to 25%, which is usually in the range of 1 liters, pressure is usually low. The patient will start having weakness, sweating, tachycardic. This is the patient that needs immediate attention before it, and when it gets to 25 to 5% of blood loss or 1,500 cc's to 2,000 cc's, usually you'll see that the patient has blood pressure of 70 to 80 millimeters mercury. The patient is usually restless, she's confused, she may not be putting enough urine, she's definitely putting out less than 30 cc's per hour, and her tachycardia is severe, 120 to 100. Massive blood loss, which is about 35%. This being very low blood pressure, she's lethargic, she's air hunger and anuria, and she might be collapsing. And that's not what we want to get to. So if you look here, I talked earlier, I said there are multiple other criteria for diagnosis that are used worldwide. So you see that the WHO tried to simplify it and just said there's a blood loss more than 500 cc's within 24 hours after birth. But then they tried to classify it further and said, well, severe postpartum hemorrhage is a blood loss more than 1,000 within the same time frame. ACOG, or the American College of OBGYN, like I said, that is the cumulative blood loss of 1,000 cc's accompanied by signs and symptoms of hypovolemia regarding mode of delivery. The Royal College of OBGYN, they tried to get a little bit minor. Postpartum hemorrhage is usually 500 to 1,000 cc's, and a major postpartum hemorrhage is once it's more than 1,000 cc's. But that included the moderate, which is 1,000 cc's to 2,000 cc's, or severe, which is over 2,000 cc's. You'll see at the very bottom, there's the California Maternal Quality Care Collaborative classification, and that one is super, super fancy, and I think that's more academically, geared, so that can be used for studies or in more academic centers and actual practical. But I figured I'll share those with you just to show you how many variations there are to classify postpartum hemorrhage. When you look at the incidence of postpartum hemorrhage, it varies widely. It depends really on the criteria used to diagnose the disorder. It also it depends on what sites are using to quantify the amount of blood loss. So you'll see if you're using estimated blood loss, it's been reported to be 1 to 5% of deliveries. But when centers, and good luck finding centers that do this all the time, but there are centers that use quantitatively measure the postpartum hemorrhage. And these prospective studies have shown that the postpartum hemorrhage rate is as high as 10%. So it really depends on how you're measuring this and how you're looking into the postpartum hemorrhage. But the incidence, I think it would be safe to say that it's about 5% of deliveries. I wanted to touch on the physiological mechanisms that limit postpartum blood loss. So normally hemostasis, we know that it occurs once the placenta is separated because uterine bleeding is controlled by a combination, a contraction of the myometrium. So postpartum, every patient will have, will describe contractions. The contraction of the myometrium, it compresses the blood vessels that are supplying the placental bed, and it causes mechanical hemostasis. And then you have two other methods, which is the local decidual hemostatic factors and systemic coagulation factors. And these two, they cause clotting. So the cause of postpartum hemorrhage is usually a disturbance or in one or both of these mechanisms or all of these mechanisms. If it's not none of these, then it's usually a laceration such as a trauma, uterine rupture, anything like that. But for the most part, it's either atony of the uterus that will cause the postpartum hemorrhage, or if there's a clotting disorder that will disrupt those two hemostatic factors. So you have to keep that in mind. If it's none of these two causes, then it's most likely a trauma. So again, simplify it: atony, coagulopathy, and trauma. These are the only causes that you should think of when you're thinking of why this patient is having postpartum hemorrhage. So I list a few risk factors. Allergies. I'd have left quite a few, but I put out most common causes and patient might that should come to your mind other than like we just, is it a diffuse for about 5% of generally easy when you can feel that the uterus is body firm, it is not well contracted, and usually you feel that after examining the patient after the third stage of labor. It can be associated with any retained tissue, placental disorders such as previa, abruption, things like that, and retained products are very common, but not a necessity. Sometimes patients, when they experience a uterine inversion, it can result in postpartum hemorrhage because there isn't effective uterine contractions that are happening, whether it's focally or diffusely. So you have to keep that in mind. When there is diffuse atony, blood usually is collected within the uterine cavity. So the patient may not be hemorrhaging as much because it's just being accumulated within the uterus itself. When there is a focal or localized atony, usually the fundal region is well contracted, but the lower uterine segment is dilated or ballooning. So it makes it a little bit difficult to appreciate it on the abdominal examination, and that's why a bimanual examination is important, so you can express any blood clots and you can feel that there is significant blood loss still happening. Although uterine atony, like I mentioned, it's usually the most common. About 75% of postpartum hemorrhage are caused by uterine atony, but you will see that it usually, most of the time, it is responsive to additional uterotonic drugs. So having said that, you will see that it's really not the most common cause for massive transfusion as delivery. When we talk about trauma during when you're evaluating a patient with postpartum hemorrhage, usually it's associated with lacerations. It could be associated with traumatic deliveries, especially forceps deliveries. It could also be associated with a C-section or ruptured uterus. When you're talking about bleeding disorders, as you will see here, it can contribute to postpartum hemorrhage with people who already, for example, have von Willebrand's disease or other acquired bleeding disorders such as amniotic fluid embolism. If they're suffered an IOFD and now they have DIC, if they have severe preeclampsia and are now developing HELP syndrome, if the patient suffered an abruption. But the interesting thing is bleeding disorders can also occur as a result of postpartum hemorrhage, where there is a severe reduction of clotting factors because there's persistent heavy bleeding and hemodilution of any remaining clotting factors. So bleeding disorder can cause postpartum hemorrhage, but at least sometimes heavy vaginal bleeding can also cause bleeding disorder. And so it just compounds the problem in that case. Obviously, other risk factors other than mentioned here on the list, you have to keep in mind any patient that has risk factors, or risk or history rather of postpartum hemorrhage. If she has a family history of postpartum hemorrhage, high parity, obviously precipitous labor, uterine overdistension such as multiple gestation, polyhydramnios, macrosomia, patients that present with chorioamnionitis are also at higher risk. And so we talked earlier about uterine inversion, and I just want you to know that at least once every 3 to 4 years we'll get that, just because there's a you need to watch out for that very um,
دكتورة
yes.
ممكن تسكر السكرين وترديه عشان تمسح الشاشة دي، مش عارف واحد من الطلبة كتب أو
Oh,
مش عارف
sure.
مش عارف
Let me
السبب.
see. I'm going to end the show and see what happens. No.
لا
Oh, maybe
سكرين.
I could.
لا
You share.
يس شير سكرين. exit share screen
I'm going to
and
try. All right.
okay.
Let me see.
exactly.
Okay. I think that's better. How is it now?
better
Why you still?
me.
Okay. All right. So, where were we? So these are some of the risk factors and specific etiologies that we've discussed. Let me just see if I can continue the slideshow. I wanted to mention a study that I came across included over 690,000 deliveries. The 4 risk factors associated with the highest odds for predicting the need for massive transfusion during hospitalization for delivery were as follow. Abnormal placentation was the number 1 factor, placental abruption, severe preeclampsia, and intrauterine fetal demise. And I want you to look at all of these 4 factors, and you'll see 3 of them we pretty much cannot control very much, but abnormal placentation, knowing that it's very high and it's very common in women with prior C-sections, is one, I think, cause or factor that we can modify a little bit. So it's pretty impressive that it is the number 1 reason for massive transfusion. So you get called for postpartum hemorrhage, and now you have to assess and manage this patient with postpartum hemorrhage. It is very difficult to say where you're going to start, what you're going to do first, which one should come in order. And I really struggled with where to put things in this slide. But, you know, you have to remember that most of the time you're doing all of these things pretty much simultaneously. So obviously, when you first get called to evaluate a patient, you need to know what her vital signs are. You need to know what the estimated blood loss is. You're going to order labs, very basics. You're going to need CBC, you're going to need the type and cross, and you need to check her coags. Coags is very important, but if you don't have the time or you think you're not going to get these labs on time, it's very easy to evaluate the patient's coags by drawing 5 cc of blood from a vein. You can place it in a dry red top glass tube, and then note the clotting time. You need somebody to keep an eye on it until it clots. The clotting time is usually 5 to 8 minutes when the patient has adequate fibrinogen stores. If this does not happen after 8 minutes, then you need to start considering, does this patient need to be given some blood products and fibrinogen as necessary rather than crystalloid, which in this case, if the patient is already depleted, if you keep just giving her crystalloid, it may just result in dilution of coagulopathy and worsen the bleeding. So please pay attention to that once you know that the patient is maybe deficient in some coags. At the same time, you're going to be emptying the patient's bladder. You want to make sure that it's out of the way. You're going to review patient's drugs. It's very important to know what drugs the patient is on. The patient maybe is on a beta blocker, for example, for treatment of hypertension. This may prevent a normal heart rate response in a bleeding patient. Histamine released due to analgesics such as morphine, it can give you peripheral vasodilation and destabilizes a compensated shock that will result in sudden hemodynamic collapse. So you need to keep all of those things in mind. I put there, ask for help. It should come, naturally to you, but I don't know how comfortable you will feel, especially when you're the junior and you're like, oh, they're going to think I don't know what to do. It is okay to ask for help. Sometimes you just need that extra person to think outside the box. Sometimes you got caught in that tunnel vision and you only see things happening and going in one direction. It's okay to ask for help. I've been asked to come in and help doctors that are maybe 10, 20 years my senior, and there's no shame in it. You need help, especially if the patient is experiencing massive blood loss. You may want to move the patient for 2 reasons. First of all, you may need adequate anesthesia to examine the patient. You may need better lighting, better staff to support you. And then once you get the patient You may want to examine the patient, determine the cause, and then um, treat it accordingly. When postpartum hemorrhage occurs after a C-section, it tends to be a little bit easier because the presence and the cause of the excessive bleeding is usually clearly apparent. You can feel that there is atony in the uterus. You can see, hopefully, if there is a laceration that is not well repaired. You can, once you deliver the placenta, tell if it came back complete or not once you clean the uterine cavity from any clots and debris. But sometimes patients, they have a slow trickle, and you may not notice it until it starts accumulating in the retroperitoneal and you've even closed the patient. And those patients, usually in the immediate postpartum, they may notice, you may notice their vital signs, and the patient may start decompensating. You can consider an ultrasound. You can do a bedside ultrasound and see if you can see hemoperineum. However, its sensitivity is very low. And so for the most part, clinical signs that are suggestive of ongoing bleeding, such as tachycardia, failing blood pressures, expanding abdomen, if the patient's level of consciousness is changing, then you really need to overrule a negative ultrasound and maybe consider opening the patient up to further evaluate where the source of bleeding might be. When you are assessing the patient, I'm hoping you're also assessing her IV access. You want to make sure that you have an adequate IV access. It should be provided ideally with 2 lines. At least one of them should be a large bore catheter, whether it's 14 or 16 gauge, and that is a must. So if the patient does not have an IV access, you need to establish that as early as possible. Most of the time, patients, should they go, start to deteriorate their case and their veins just collapse, it's very hard to start an IV line. So you want to establish that early on. Most patients, you start just resuscitating them with crystalloid, usually an isotonic crystalloid. If the patient, like I said, you suspect that they may be having coagulation factor deficiencies, you may want to consider blood products. Just remember, if in our institution, at least, I don't know how it is in your blood bank, for every 4 units of packed RBCs, we have to give the patient 1 unit of fresh frozen plasma. Any patient that is going, or you think it is hemorrhaging massively, that she may go into shock, you want to make sure you avoid hypothermia and acidosis. As we all know, hypothermia results in sympathetic stimulation, which increases myocardial oxygenation consumption. Particularly if shivering occurs, you have to be careful with that. This might lead to myocardial ischemia. So you want to avoid that as much as possible. So if you have a heating blanket or if you have warm blankets, just make sure that the patient remains warm. Other obviously, side effects or consequences of hypothermia include sepsis, bleeding disorders, the platelet function is reduced, there's an increase overall in mortality. So you want to make sure that you keep the patient warm. Also remember, the combination of hypothermia and acidosis, it does increase the risk of clinically significant bleeding despite adequate blood, plasma, and platelet replacement. So acidosis should be corrected. And usually when the patient gets to that stage, hopefully she's in the ICU and you are checking her ABGs regularly. But any pH less than 7.1 should be corrected to avoid acidosis and further increase the morbidity of the patient. Obviously, you want to make sure you did examine the lower genital tract and the uterus. For the most part, again, if it's a C-section, it's a little bit easier because you know where to be looking for. But for a vaginal birth, just make sure you do assess the vagina, the cervix, and also the uterus for a possible uterine rupture. You should have a higher index of suspicion if the patient had a trial of labor after a C-section. However, spontaneous rupture of uterus can happen. Usually the most common risk factor is grand multiparity, patients who have been pitted all day, they're being induced or augmented with Pitocin, patient that maybe had a prolonged 2nd or 3rd stage of labor. In those patients, when it's not a scarred uterus, for the most part, the rupture is in the posterior wall of the uterus. So when you're evaluating or exploring that patient, make sure you pay attention to that. Like patients who had prior C-section, which usually the rupture is at the site of the old scar. I don't know if you have TXA, but TXA is an fibrinolytic drug. We usually give it as we're giving the other medications that I will mention in just a minute, which are the uterotonics. And what it is useful because fibrinogen depletion is common in the early stages of major postpartum and traumatic bleeding. And if you don't give it early on, it reduces the benefit. So we usually give 1 gram. We infuse it over 10 to 20 minutes. It's very important that you give the directions, because infusing it of more than 1 cc per minute can cause hypotension and worsen the patient's situation. So please be mindful of that. You can also repeat it after 30 minutes if the patient is still bleeding. And it's usually good for about 7 to 8 hours. That's usually the duration of action, is up to 7 to 8 hours. When we talk about uterotonics, the most common, obviously, oxytocin. We usually have it pre-mixed. It's 30 units in 500 cc solution, but you can also give 10 units IM if you don't have immediate IV access if you need to. Methergin is very commonly used. It's usually 0.2 milligrams IM and usually 4 hours. Just make sure that there are not contraindications. The most common is going to be patients with hypertension, as it can cause hypertensive crisis. So be mindful of that. Carboprost or Hemabate, you can usually give 250 micrograms IM and repeat it every 15 minutes for a maximum of 8 dosages. But be mindful of patients who have history of asthma, as it can exacerbate that or give the patient an acute asthmatic episode. Misoprostol is commonly used. We usually give 800 micrograms rectally, and we rarely have to repeat that. It's pretty potent, but any of the above is fine. Non-medical management of postpartum hemorrhage. So if the patient does not have atony, or she does have atony, but she failed all of the uterotonics, we'll talk into detail about the use of uterine balloon or packing, but obviously non-medical management, repair any vaginal cervical laceration, any uterine rupture. A uterine balloon or packing is something that we use very freely. We usually, actually, for a uterine balloon, there is a Bakri balloon, but if you don't have it, most of the time we just use a number 24 Foley catheter, and we fill the balloon with about 30 cc's of normal saline. Make sure you're not using air to provide any air embolism. Fill it with 30 cc's of normal saline. And anytime you're inserting anything inside the uterine cavity, please be mindful that the patient may need antibiotic coverage. So you could start the patient on a broad spectrum antibiotic, especially after exploring the patient or, having significant manipulation in the vagina, or, feeling for any uterine rupture. So we usually start with gentamicin and clindamycin, or gentamicin and flagyl. These are usually broad spectrum enough and should cover. If you are to do any curettage, or you suspect that there is a retained products of conception or placenta, please be gentle with the curettage. Uterine artery embolization, this is usually done by an interventional radiologist, and I don't know how readily available it is in some of our hospitals. I'm guessing in tertiary care centers, but I bet you in places like Al Jala, they probably do not, but that could be an option too. And then laparotomy is a last resort, whether you need to repair a uterine rupture or a cervical laceration that extends further up. Sometimes in resistant cases of uterine atony that have not responded to any medications, you can do a compression suture, which is the B-Lynch suture, and I'll show you a diagram of how to put in a B-Lynch suture. It's very helpful, it's very effective, and usually you would know right away if it's going to work or not. Bleeding continues despite all of your other heroic efforts. You can try a uterine or hypogastric artery ligation. I do not recommend you do that unless you know how to do it. We usually either call a gynecological oncologist to come in and help us with that, or we usually have a urogynecologist come in and help us with that, as we're not very familiar. I'm not mentioning here hysterectomy, but obviously that can be an option if all this fails. So this is the B-Lynch suture, and I want you to think of one thing. So the purpose of this B-Lynch suture is really with the manual compression of the uterus. You are mimicking a contracted uterus. You reduce it down, and then you're putting this suture to keep it in that position. So what usually happens, you take a large Mayo needle, usually take a number 1 or a number 2 chromic catgut. Usually we prefer catgut because it's obviously absorbable, but any other absorbable suture is okay. But the faster absorbable suture, the better. We usually use it to enter and exit the uterine cavity laterally in the lower uterine segment, as you can see in the diagram. And it is very important that, again, I want to reiterate why it's very important that we use an absorbable suture. Is a large suture, it's usually used to prevent breaking, and a rapid absorption is important to prevent herniation of the bowel through the suture loop after you have the uterus that has involuted. So that's why the earlier it absorbs, the better. The suture is then, after you've entered anteriorly, it is looped over the fundus and then re-entered the lower uterine cavity through the posterior wall. It then crosses to the other side of the lower uterine segment and exits to the posterior wall. And then you loop it again anteriorly. Excuse me. You loop it again over the fundus anteriorly, opposite and parallel to the initial bites. The free ends are then pulled tightly and tied down securely. While you're doing that, you have an assistant that is bimanually compressing the uterus to keep it down. And then you inspect for the bleeding, for vaginal bleeding usually, and you can assess whether this is effective or not. So there are multiple videos, I'm sure, on YouTube on how to do the B-Lynch, but it's a very helpful tool. I like it. I've given you some checklists here, some organizations, definitely our hospital, what we use for usually once a postpartum hemorrhage code has been called. Usually you as the physician will then have to designate who is going to be your runner, who's that person. Usually is whether it's a medical student or the intern, or if you do not have any, then it's usually one of the nurses. That is the person who will be running to grab the medication for you. That is the person who will be running to take the labs down for you, bringing blood to you. So that needs to be known who that person is, and that would be their only job. Then you have somebody who's charting, because it's very important to write down what medication have been given, what time, what dosage. And you then, whether you've asked for help or not, but usually anesthesia needs to be notified at some point, especially with a stage 2 or stage 3 bleeding. So this is just a helpful resource just to show you what some places are doing in terms of postpartum hemorrhage protocols. So planning and prevention. Wouldn't it be nice if we can know exactly who will have postpartum hemorrhage and who will not? Sadly enough, we can't. And still, most of the cases of postpartum hemorrhage are coming or happening in women who don't have very obvious risk factors. However, having said that, women with risk factors, they should be identified and counseled. So any patient that has history postpartum hemorrhage, a grand multip, patient that comes in with placenta previa, patient who's attempting a trial of labor after a C-section, patient who's having multiple gestation, whether we know that she has any coagulation disorders such as von Willebrand's or not, if the patient has a large, for gestational age, baby. Planning for these patients is not only, it involves really ensuring availability of resources that she might be needed. It also makes sure that you have the personnel that you need should bleeding occur. You have the medication that you might need handy. You have the equipment. You have adequate IV access. When she gets admitted, this is probably not going to be a patient that I will say, well, if you don't want the IV access, then maybe, she's progressing so fast, you may not need it. This is and a large bore IV access, at least 2 of them. And you want to make sure you can have access to blood products easily. So you don't want to be delivering her at a birthing center or something like that. those patients, obviously, again, they should be really planned to be delivered in a facility that has all of this appropriate level of care, should they need it. So, keep that in mind when you're counseling those patients. Go with your gut. If there is any potential risk and you think she may have postpartum hemorrhage, it is not worth risking it and saying, I think she'll be all right, and we can deliver her maybe in a small private clinic or something. If you think she's a high risk postpartum hemorrhage, you may want to be in a more well-equipped area. And those patients, you may want to even consider maybe active management of third stage, whatever that might be. We usually give 10 units of Pitocin with the delivery of the anterior shoulder, whatever your protocol might be. I know in Libya, sometimes you also use Methergin for active management of a third stage of labor, but you may want to assess the situation and see if this patient would be a good candidate. So again, this is a diagram that just shows you, patients that might be at risk for postpartum hemorrhage, but it's a low risk, medium risk versus high risk. So just again, it might be helpful to look at and decide. So mortality and morbidity associated with postpartum hemorrhage. So you'll see the overall mortality is about 0.2 to 20%. And that's a very, very wide range. This wide variation worldwide is really dependent on the overall health of the pregnant woman, her initial hemoglobin, and also resources available for treatment of postpartum hemorrhage. When you see that 20%, that's usually more in African countries and really underserved rural areas. So it's a wide range. And it's very sad that it can be as high as 20% because it's something that could, with the right resources and treatment, it can be corrected. The other, morbidity associated with postpartum hemorrhage is transfusion. So patients that had postpartum hemorrhage, there was one study that we looked at, and it was actually through my university. So they looked at and they saw that 54% of women who had massive postpartum hemorrhage required blood transfusion. You have to think about that. Risk of transfusions are very high. There's risk of infection, electrolyte abnormality, allergic reactions, and volume overload. So, to think that massive postpartum hemorrhage and be associated with 55% is further complicating the situation in a woman that's already been compromised. Hysterectomy. And there was a trial, it's called the woman trial. 3.5% of women who underwent a peripartum hysterectomy was because of postpartum hemorrhage. Hysterectomy was more common in women who had other causes of postpartum hemorrhage other than atony. So women who had postpartum hemorrhage because of atony accounted for only 1% of the patients. Thromboembolism. So in trauma patients, transfusion is an independent risk factor for the development of thromboembolism. So for that reason, we usually recommend that women who have been transfused for postpartum hemorrhage, they should have mechanical thromboprophylaxis. Whether you choose to do a graduated compression stockings or you want to do a pneumatic compression device, as soon as feasible, you need to put those on. And this should be continued until the patient is discharged home to prevent any DVT or thromboembolism. Hemodynamic instability and organ failure. In the woman trial that I just mentioned, 60% of women with postpartum hemorrhage, they had clinical signs of hemodynamic instability at diagnosis of the postpartum hemorrhage. And almost 40% of those patients, they developed whether it's renal failure, heart failure, respiratory failure, or hepatic failure. So treatment of hemodynamic instability requires fluids and blood. And these things, unfortunately, can also lead to fluid overload, resulting in pulmonary edema and dilutional coagulopathy. So it's a very tricky situation because especially when you're first called in and the patient is just hemorrhaging, your initial instinct is to just keep pushing fluid. And sometimes that could complicate things for you later. Sheehan syndrome. So when you think about postpartum hypopituitarism, it is rare, but it is potentially life-threatening complication. As we all know, pituitary gland is usually enlarged in pregnancy and is very prone to infarction when you have a hypovolemic shock. So something to keep in the back of your head. Asherman obviously is the development of intrauterine adhesions, and this can lead to menstrual abnormalities and, most importantly, infertility. Unfortunately, about 90% of cases of severe Asherman's or intrauterine adhesions disease are related to uterine curettage for pregnancy complications such as postpartum hemorrhage. So that's why earlier when I said you do curettage, please make sure that it's a gentle curettage. Recurrence. So we do know that women with a prior history of postpartum hemorrhage have as much as 18% risk of recurrence in a subsequent pregnancy. So you need to screen those patients, and when they get admitted, keep that in the back of your head. Especially some cases, like if the patient has history of postpartum hemorrhage because of an abruption placenta, we do know that the risk of recurrent abruption is about 5 to 15%. So you may want to keep that in the back of your head. When a patient comes in and there was, history of postpartum hemorrhage and no true etiology was ever identified, you may want to think about previously undiagnosed bleeding disorder, especially if the patient also gives you a history of maybe heavy menstrual bleeding. Maybe she tells you that she has excessive bleeding after minor trauma, or she has a family history of bleeding disorder. So these are all factors to keep in the back of your head. Ideally, you would not screen for those patients as she's about to deliver. Hopefully you've done that either in the immediate postpartum after her first delivery when you did not have a good reason for why she suffered a postpartum hemorrhage, or early on in pregnancy, so you can be prepared should you make a diagnosis of, say, von Willebrand's disease. So with that, I want to say that having a postpartum, having to deal with postpartum hemorrhage can be pretty challenging. Thankfully, it's not very, very common, but when it does happen, it can be pretty catastrophic. And so I'll leave you with this quote. And basically, it's Stephen King saying that there is no harm in hoping for the best as long as you're prepared for the worst. And I would like to touch on one more thing, just because I'm very passionate about it. With postpartum hemorrhage, I've had one friend and one friend of a friend that passed away in Libya because of postpartum hemorrhage in the last 3 years. These are just people that I know directly or know of somebody who knows them. And I think in both cases, it was related to a placenta accreta spectrum. So if you know, placenta accreta spectrum can range from accreta, where the placenta is implanted in the myometrium, increta, where it's implanted or invaded into the myometrium, and percreta, where it goes beyond the uterine wall, the serosa, and could even attach itself to other neighboring organs. Most commonly, it is the bladder. So just to put it into perspective, when you had one C-section with a placenta previa, the chances of having a placenta accreta is about 3%. Having 2 C-sections, it's 11%. Placenta previa with accreta is about 40%, and 4 C-sections, 60%. So please, before you decide to give a patient a C-section and commit her to repeat C-sections as a mode of delivery, especially in our society where most moms are having 3, 4, and 5 kids. Just think of that risk of placenta previa and the complications of placenta accreta spectrum should that occur. And like I said, I'm very passionate about it because I know of at least 2 moms who died very young because of complications after having a C-section and developing postpartum hemorrhage. So with that, I would like to see if anybody has any questions.